Who finds this hard? No? Hand up for who finds it difficult? 2. Anyone else? Okay. You find it all right? It's fine. Okay, I'll ask you questions. So basically, guys, yeah, look. This is just for plab. Yeah? There might be a few things wrong here, but for understanding purposes, okay? This is your. It's not even working. This is your bloodstream. Bloodstream, okay? Bloodstream in your blood, okay? And you see your red blood cell. Your red blood cell basically, it comes from where? Now I want to join a bit of hematology because I'm doing the next, okay? You know, in a bone marrow, yeah, it's made there, isn't it? Yeah. First they make reticulocytes, isn't it? Yeah. First, small baby RBC, isn't it? Okay. They go into the blood, yeah, and then they go into mature RBC. They have no nucleus. RBC lives for how many days? 120 years. Yeah. Days. Okay. Yeah, days. Yeah. And then they okay, and then they die. Okay. Then they die, and then we have to do janaza. Okay. Okay. So in here, one of them is bilirubin. Okay. We have unconjugated bilirubin. Okay. Unconjugated bilirubin. Does that make sense?
Yeah. Is with the janaza life?
This is life. Yeah. Unconjugated. Does that make sense? This is very simple. It's like ABG. If you understand, everything is easy. Does that make sense? Yeah. Yeah. Go on.
I didn't understand it. Actually, I didn't listen to what you said.
You see this red blood cell?
Yes.
When it lyses, sometimes it breaks down in the blood vessel. When it lyses, hemolytic. When it lyses, it could be anything. Okay? Maybe, remember you did an HUS yesterday? There's a small thrombus and breaks it?
Yes.
Yeah? So it lyses. Or it could be anything. Imagine you have a sort of a gun and you pop it. Whatever, yeah? Antibody, complement, whatever, doesn't matter. Intravascular hemolysis. Does that make sense?
Yes.
It breaks down. Inside is hemoglobin. One of them we need to know, only one of them, is the bilirubin. This bilirubin is special, it's unconjugated, meaning it has to be more modified. It can't leave the body, it is insoluble. Okay, so what happens is that this bilirubin, it travels, you're going to have your albumin. Albumin is the most common protein in the bloodstream. So in nephrotic syndrome, they have hypoalbuminemia. So therefore, they have edema, too much tissue. Yeah, water. I mean, so this carries it to our liver. In the liver, we have unconjugated bilirubin, and there is a special enzyme. Forget the name. Let's put enzyme. It makes this more better, called conjugated bilirubin. Now this conjugated bilirubin, it can leave the liver, and because it makes it so much, it has to be stored. And here you have your gallbladder, right? It stores it in the gallbladder as bile, right? And then it also goes, after that, some of the bile is going to go into your duodenum, into your bowel. That's the color you get of your stool. Okay? So the problem is that you get jaundice because of increased bilirubin. But we're not sure, is it this one or this one? Because they're a bit different, isn't it? So now jaundice is yellowish of the skin because of bilirubin. Bilirubin has no meaning to us. Could be this or this, we don't know. And different pathology, right? So let's do one of them. Yesterday we done Gilbert syndrome, right? So these patients, remember I said, their enzyme is slightly less working. It works, but it's slightly less speed. So at the time of stress or infection, what happens is that normally imagine that there's 100 of them. In time of infection or stress, it works less. So it only does, let's say, 90 at a time. So 10 of them are remaining, isn't it? over time 10, 20, 30, and they can't really be in the liver all the time. So it backflows into the bloodstream. And then you have yellowish. Does that make sense? Yeah? But the thing is, what is yellow in the blood? Which bilirubin? Is it unconjugated or conjugated? Unconjugated. Very good. Unconjugated, yes. So hepatic picture. Hepatic picture means it's a bit like your kidney. Intrinsic, postrenal, prerenal. Okay? So hepatic picture means that you have jaundice because of a problem with the hepatic, with the liver itself. And these are the causes, is liver. So Gilbert syndrome, problem with the liver, isn't it? Yeah? Alcohol, liver, viral, and so on. So alcohol hepatitis. These patients will have hepatitis because of alcohol. So how do you know if it's alcohol hepatitis? So the liver will be inflamed, hepatitis, because of alcohol. So these patients, very important in the exam, you see they have high MCV. High MCV, okay? High MCV. And they will have high amount of GGT. So with regards to our liver enzyme, we have ALT, we have AST, we have ALP, we have GGT. In here, for alcoholic hepatitis, if you see high GGT or high MCV, with alcohol history, thinking of alcoholic hepatitis.
So, ALT or AG ratios 2:1 also.
No, this is alcoholic, just focus on this one. High MCV and GGT, okay? Now, alcohol will have a history of, it can cause liver cirrhosis. So you may have all of these things, spironolactone, stigmata of chronic liver disease. So alcoholic hepatitis, history of alcohol, and don't forget these two things to understand. So second thing is viral hepatitis. Viral hepatitis. So A and E. A and E stands for what? Accident and emergency. So this is how I remember. Hepatitis A and E. They are fecal to oral. Rest are not. So I associate A and E together. And I remember accident and emergency, A and E. They are fecal to oral transmission. So hepatitis A is fecal to oral route. Self-limiting. One of the cause of traveler's diarrhea, very important. One of the cause of traveler's diarrhea. If you want to know which one is acute and chronic, IgM and IgG. IgM is acute infection. IgG can persist for many years. So learn fecal to oral. Number 2, learn traveler's diarrhea. Learn this investigation. M for acute. Hepatitis E is also fecal to oral route, similar to A. One thing you need to know is pregnancy. Mothers who get it in the last trimester, they have high mortality. So pregnancy and E, hepatitis E. Hepatitis A linked with traveler's diarrhea. This is with pregnancy. IgG for acute. No, it's wrong. IgM for acute. Yeah, IgG for chronic, persistent. So hepatitis A and E, don't learn too much. Fecal to oral, pregnancy, travelers. B, focus B. These things, I'm not going for it, we all know these risk factors. Here, obviously IV drug abuses and so abuses, homosexual and so on, okay? Now, antigens. HBs, surface antigen. So this is your virus. On the surface, you have an antigen. This is called surface antigen. Acute infection, positive. Leonard, acute infection, positive. If a patient has an infection of hepatitis B, is that acute, is that chronic, we don't know. Surface antigen will tell you. If it's there, it's going to be acute. Second thing is, sometimes it is not enough. This surface antigen is not enough. You need one more thing, because of the fact that it can also be in chronic, it can persist as well. So if it's in acute and chronic, it's either of them, isn't it? So we need one more thing. Here, IgM, HBC. So IgM, again M for acute. Okay, HBC, core, C for core antigen. So in summary, surface plus IgM core, both of them acute. Is that okay? Now, other things, opposite of acute is chronic. We need to know chronic. In chronic, I mentioned to you guys, yes, you can have surface antigen, but to differentiate from acute, IgG, HBC core, IgG. Is that okay? Then moving on, I want to focus on this thing. Those people who have vaccination or those people who are naturally immune to it. So if you have hepatitis B vaccination, vaccination, they don't give you. 1 second. Anti-HBS. Okay, so I think this should be here HBC. HBS? You sure? Is that which antibody? Is it? So this one, don't quote me. I actually forgot now because this is so obviously you have to remember it all the time. So I'll go over quickly. Immune, natural, and vaccination. You need to know the differences. They ask you in the exam sometimes. These two. So afterward, check it up. Okay. If not sure, let me know. I'll check it up myself. I just forgot, so I don't want to give you false information. So check it up. Okay. But I think this is correct. But I can't sort of recall how it works. But immune and natural, know what is positive, what is negative. Hepatitis C, you can only, so this is again IV drug abuse and so on, okay. Investigation. RNA, hepatitis C virus RNA for infectivity. Second thing is that the hepatitis C only is positive after 3 months. Hepatitis D, you can only get it if you have hepatitis B. Key focus should be on hepatitis B, knowing this antigen antibody. Non-alcoholic fatty liver. Please highlight, this is the most common cause of liver disease in developed world. Factors here: obesity, type 1, hyperlipidemia, and so on. Ultrasound pictures, you need to know increased echogenicity on ultrasound. ALT is greater than AST. Enlarged liver. Know these risk factors here. This is non-alcoholic fatty liver disease, the most common cause of liver disease in developed world. Liver cirrhosis. Liver cirrhosis, alcohol, I mentioned to you guys, non-alcoholic and viruses. liver cirrhosis, the best way to diagnose or the most definitive, biopsy, liver biopsy. Okay. Okay, moving on to obstructive jaundice. Okay, so this is our beautiful diagram. So as you can see here, this diagram shows our liver. Our liver is here, our gallbladder is here, and our duct, bile duct is here. So this is the thing you need to understand. So problems around here, all of the bile duct getting blocked, is post-hepatic. Okay. Problem here is going to be hepatic. Problem before, pre-hepatic. So obstructive jaundice. Okay. So as you can see, there is an obstruction. Okay. So there is an obstruction. So let's put this here. There is an obstruction here. Okay. So things can't get through. Does that make sense? So are things building up or not? So this patient is going to be jaundice or not? Yes? Okay, so Alenza, this patient will be jaundice, right? So we're talking about obstructive jaundice, Alenza, yeah? He'll be jaundice, yeah? Will it be conjugated or unconjugated? Both. Huh?
No, conjugated, because it's already conjugated in the liver. It doesn't come down.
Conjugated. Yeah? It's going to be more conjugated. So it's going to be, so mostly it's going to be conjugated. So you need to know high conjugated. Second thing you see, you're going to have pale stool. Why pale stool? Because it's not going into your stool. It's blocked. Dark urine. Why?
So some of the
Yeah, because some of them is going into your It's not going to urine, is it? No, because when it goes into your GI tract, some of them gets reabsorbed into the urine, isn't it? Intestine and back to the urine, isn't it? So pale stool, dark urine. So any jaundice, you see this first one, obstructive. That's the clinches here. So you don't see any urobilinogen in urine. That's why it is dark. Because once it goes into your intestine and everything, okay, some of them gets reabsorbed into the body and then into the kidney. Because this conjugated, it is water soluble. It's water soluble. That's why it normally goes. You know, you have babies who have jaundice. What do you call it? So, huh? No. So, and you know, babies who have jaundice, right? You done peds, okay? We give them. What do we give them? Phototherapy. Okay, and quite common in those who are premature babies. Yeah. Do you know why phototherapy? Because they have bilirubin which is unconjugated, and we make it conjugated. Why? Because so therefore they can pee it out. It's water soluble. Okay. All right. So hepatic. We said that these things you need to think about it. Post-hepatic. Okay. Sorry. So post-hepatic blockages. One more thing you need to know. Any blockages, right? For example, you have a gallstone blockages there. ALP will be high. ALP. Alkaline phosphatase. Another clue. ALP. So let's recap, guys. So pre-hepatic, you have jaundice, which is unconjugated, okay? But it's not affecting your liver. So your liver enzyme, which is your ALT, your AST will be normal. There is no blockages, so this will not be raised. Everything normal. It's just they are jaundice and they have this raised. If it's in the liver itself, obviously you're going to have elevated ALT and AST. Obviously you're going to have a high amount of bilirubin, okay? And there are so many causes, okay? If it's post-hepatic, we know, very obvious. Obviously you will have jaundice, high ALP. ALP will be high because of blockage. Every blockage, high ALP. PCP, primary biliary cholangitis. Before it was called primary biliary cirrhosis, okay, first thing you need to know is it's autoimmune disease. Female here, very important guys. Itchiness, pruritus. Investigation, they ask you in the exam, anti-mitochondrial antibody. This is the best one. This is the most diagnostic. Okay? They have no gallstones, because if you read about it, you think that this patient can have gallstones, but it's not a gallstone. This is primary biliary cholangitis. This is an autoimmune disease. Okay? So you have destruction of your small interlobular bile duct. This causes intrahepatic cholestasis. Female, age, this rash, jaundice is important. Investigation, second one is very important. Management, cholestyramine for itchiness. The treatment of choice though is going to be this urodeoxycholic acid. Surgical is the best. But if you look into here, what is this? Your gallbladder. You store bile there, right? Okay. Remember, if you have, and this is your cystic duct. If you have a stone there and that inflames that area, it's called cholecystitis, acute cholecystitis. Okay. Patient with acute cholecystitis will have methicillin positive, and initial investigation is going to be. What's the most appropriate going to be? Ultrasound. Ultrasound. Yeah. Ultrasound will show this inflamed. As you can see here, this is the duct, isn't it? Bile duct. Can you see? It is a bit like Crohn's disease. Okay. So you have these sort of strictures there, right? So this is called primary sclerosing cholangitis, PCP. This is important. Out of all of them, this is one of the most important thing. Primary sclerosing cholangitis. Okay, you need to understand this. Okay. Now, as you can see here, guys, these ducts they have strictures in it, strictures there. So they are fibrosing strictures coming together. So it's like a blockage. Do you agree? It's like a blockage, right? So therefore, if it's a blockage, things can't come out. You're going to have jaundice. Yeah? You're going to have also pruritus and pain there. And the liver will go big because backflow, right? You're going to have raised ALP or GGT, and bilirubin may be raised. Now, in this one, initial will be ultrasound. We will show this one. Show bile duct dilation. Okay, because of the blockages. But the investigation of the choice is going to be MRCP. Now, given said that, if a patient now has fever, so as you can see, you have sort of strictures there, so there and everywhere. As you can see, look here, you have, can you see strictures there, right? So bile, can it go in? No. So you have bile stasis. Anything that gets stuck there, risk of infection. Okay, so from upwards, normally you see the bile comes down and goes down, right? And it's very near your what? Intestine, isn't it? Duodenum. And that's full of bacteria. Okay, so that flushing every day is very good. So it prevents that backflow of bacteria going into here. But that flushing is now stopped, isn't it? So they can creep up slowly, isn't it? And can cause infection. Same with stone, kidney stone, it gets stuck there. There's no flushing of the system. So bacteria comes upwards from the bladder. Okay, causes UTI, causes pyelonephritis. Common cause is E. coli because of the same principle behind it. So these patients can get illness, become very, very unwell. If they become unwell, then it's a different thing. We call it, this is the ascending cholangitis. Ascending means bacteria goes upwards. Cholangitis, inflammation. So therefore, you need to know this one. Any patient with jaundice and fever, is this. Jaundice and fever. It's tired is pain as well. Jaundice, fever and pain. This patient can be very, very unwell. Then it's called the Raynaud's pentad. They have all of these things. They become so unwell, sepsis, hypotensive and unconscious, or decreased level of consciousness. Jaundice in pregnancy, please know this one. Symptom relief. Okay. And that's pretty much the summary, the main points for your GIT.